Right, good afternoon, everyone. I think we'll get started if that's okay. I know there are still people joining, but I think the value of these webinars is in the richness of discussion. So the more time we have available to have those discussions, the better. So it gives me great pleasure to welcome everyone to today's webinar. It's the first of an ongoing series of webinars which ECIST are providing, which are aimed at ward-based clinical teams. They are open for everyone to attend, and we've got a series of webinars based on a number of themes. We're going to kick off today's series and the webinar with my colleagues from ECIST. So I'm delighted to welcome Leigh Forsyth. I don't know if Leigh wants to give us a quick wave. Lovely, thank you. Jyothi Nippani and Amit Arora. So Jyothi and Amit are both regional clinical directors for ECIST. Jyothi is also national clinical lead for reducing in-hospital length of stay, and Leigh is a senior improvement manager with the ECIST team. We've also got behind the scenes Crystal, who is supporting the programme. Just for the record, Crystal, if you unmask yourself and give us a quick wave so we can see you. Lovely. Thank you very much, Crystal. Nice to see you, and thank you for all your help and support. So today's webinar is going to be looking at our Rapid Improvement Guide, which was refreshed and released about 4 weeks ago. We looked at this at a short space of time over the winter period, and we have a variety of Rapid Improvement Guides that are sort of, if you like, one-stop shops for teams who really want some ideas and some case studies. They're really easy to access, and they're full of top tips to help improve patient flow. So today's one is going to be focusing on improving weekend discharges. I'm going to hand over to my colleague Leigh, who's going to hand over to Amit, and then we're going to bring in Jyothi, who's going to give us a case study from her own organisation of how it's been implemented. Please put any questions in the chat box, and then we'll open it up for discussion, hopefully in about 20-25 minutes. So thank you very much, Leigh.
Brilliant, thank you, and thanks for the introduction, Andrew. So, my background in physiotherapy, currently working in ECIST, as Andrew said, as senior improvement manager for therapies and social care. And myself and Amit coordinated the putting together this rapid improvement guide. So we thought it'd be useful to talk a little bit about how we develop it. I think that's really, really useful to understand some of the background, and also and then go on to about some of the detail within it and some of the application of it and how you can use it. Next slide, please. So this is probably one of my favourite quotes. You know, I've a real background in quality improvement. I think there is something around. There are so many opinions flying around in this particular space. We've known for years that weekend discharge is a challenge and a particular issue, and lots of people have got their thoughts and views on this. And so there's something around we've got that data to inform this. So I'm getting a lot of feedback from people. So you can stay on mute, please, if you're not speaking. That'd be really, really useful. And so I want to take a bit of a leap from one of the most inspirational quotes and probably inspirational quality improvement leads to this, which was a sign I saw in a hospital in Salisbury. It was in the toilets, which I know is a bit of a leap of faith from where we started and what we're talking about, but bear with me. So there's something for me around, if you start looking at this particular sign, the problem is obviously really, really clear that people are flushing toilets. I mean, hand towels down the toilet. The solution has been to create a sign. And so I'm going to take a couple of minutes for you to start thinking about actually most rational humans don't do things to, on purpose. So there's something for me around actually start thinking about actually, well, what is the root cause to this? Why are people flushing? These were green paper towels. They weren't. There's probably a much wider problem in this particular area that is making people put hand towels down the toilet. And so just putting a sign up is probably the wrong solution to it. It seems simple. And I think this is the whole thing around that fast thinking fast and thinking slow. There's type 1 and type 2 errors that actually jumping to an immediate solution may not necessarily be the right solution. It seems simple, but not all of the answers are particularly simple in this particular area. And I think this is almost where we started with thinking about the backgrounds to the rapid improvement guides with this, that actually some of the most simple solutions might not always be the right ones. Next slide, please. So where we started, we start thinking about what is the data showing us. So we know weekend discharges are about 40% lower than weekdays, which I'm not going to labour on too much. We started off with our data, and actually how do we then start thinking about this? So we started looking at reviewing all of the published literature, and we started looking at the grey literature as well as the published articles, and quite a rapid review of this literature. We have a number of clinicians and doctors working with us, trying to pull them together. Actually, well, what do they know worked well? Where do we come? Where has worked? What has worked for them? We also try and get some input from some of our improvement managers that are working on the front line and actually be able to test some of these hypotheses. They don't come up with a huge list of ideas. Next one, please. So, and once we start getting all of these ideas, all of those possibilities, and with that divergent thinking, it's surprising how much overlap there is of high-level themes. Actually, there's loads of initiatives. They're called slightly different things, slightly different language in the published literature or on local initiatives, but actually they're quite common themes sort of come up. So actually, that's almost how we get to the rapid improvement guide, is actually trying to pull together all those divergent thinking and put it into a much more convergent way. Okay, next slide, please. And what we ended up was a fairly simple mnemonic. Thursday think, Friday finalise, weekend work, Monday monitor, and it's really sort of based upon that the principle that actually, as we both have almost, I think this is quite from quite a while ago, we're two jobs as clinical leaders. We're here to lead clinically, but also to improve what we do on a daily basis. So actually, how can we keep doing that? How can we keep understanding the why? How can we apply that to this particular problem? And how do we then make sure we're picking up what the issues are at a local level and being able to adapt and change them? And so I won't go into this in too much detail because we're going to go through it in my colleague Amit's going to go through it in the next steps. But it's to try and just sort of break down the tasks and trying to have that continuous learning loop and what's the continuous PDSA cycle applied to a clinical situation. Okay, next slide. And over to you, Amit.
Thank you, Leigh, and thank you all for joining. I'm Amit Arora, and I'm a geriatrician based in the Midlands. So continuing on the theme of the weekend discharges, and as Leigh said, we are all clinical leaders and we have to understand our why. And I think it's really, really important to understand, to ask ourselves, what is our why and why do we do what we do? And I suppose we are in the healthcare areas to save lives, to improve outcomes, and to help others, and to make things better. And that is what drives us. And as clinicians, we are leaders in not just healthcare, but also leaders in improvements and innovations. And why do we want to do good work? Because we want to be proud of our work. But you have to find your own why. Why do you do what you do? But if we move on to the slide on the Thursday is relevant because Thursday is to think and Thursday is to act. To think, what did we learn? What did we learn from the Monday audit, which we'll come on to a bit later? And the weekend plan that we may need to do differently on this weekend. What actions have been taken to make it easier on this coming weekend? One of the things is around EDDs, the expected date of discharge. Very common, a lot of people use it, most of you know about it. And the progress of every patient towards their EDD should be assessed and recorded every day at a board round and reassessed during the board round. As clinicians, we feel that we know when the person may be going home, but the EDD, what does it do? The EDD gears other staff and patients to anticipate and plan and arrange things for their discharge. It enables families to plan things. It gives the patient hope of going home. And if you are in any doubt about EDDs, just tell your next patient, when can they go home? And the smile that comes on their face will give you the answer that might be your why. The next bit is around criteria-led discharge. And I won't say much around this because we got a lot of this covered in Jyothi's presentation a little bit later. But every patient should have a clear plan, which should include clinical, functional, and social criteria for discharge in the patient's notes so that other staff are aware of those plans. Next bit around this is the news to decision support tool or other inpatient decision support tools. And no one is saying that one should base their clinical decisions on the news to alone or any other such tools. But what it might do for you is that you may find this tool useful to trigger a clinical question in your own mind regarding an individual's need to continue to stay in the hospital and to consider other ways of providing ongoing treatments and care for the patient after discharge and in other settings. Forecasting is something which is a real issue in which many patients are not really fully sighted on what is forecasting for their particular hospital or department or ward or emergency department. What we know is that the flow through this emergency department in all hospitals is highly predictable. However, these predicted attendances are not in sight of most clinical staff. At least it was not in my sight until such time that I got involved in these things. But these forecastings are actually available and they are routinely discussed in your bed meetings and senior meetings and system meetings. And if you ask your organization to send them to you on a routine basis, they are fairly easy to obtain. But as a clinician, why do you need this? Remember, we are not just clinicians, we are all leaders, and it is our business to know this. And understanding that expected demand by using a rolling forecast available from these bed meetings can actually help you anticipate peaks and to help with your workforce plan. And we'll come back to the workforce plan a little bit later. Next slide, please. So coming on to Friday. So Friday is really, really important because on a Friday, you can actually develop those weekend potential discharge lists, and ward-based teams identify those patients who can be potentially discharged as they are medically stable or medically optimized for discharge or transfer. And such potential discharge lists can actually help focus the attention of the teams working prior to and over the weekend to support these discharges. Innovative teams have developed various ways and means to signpost the weekend teams and ward-based staff. For example, some hospitals have used a Friday sticker or a Friday stamp, which they use to put in the medical notes. And what it does is it identifies and highlights which patients are for discharges to the teams who are working on the weekend. So a simple solution. These are various types of clinical, physiological, and functional criteria. And I might give you, for example, it might say the consultant has documented on a Friday that if the patient is afebrile, the CRP is less than 50, can walk to the toilet, and a care package is arranged, and nothing new happens, the patient can go home. What a clear definition like this does is it gives the weekend team the clinical confidence to actually discharge that patient. Otherwise, what will happen is the junior doctor or the senior nurse or the consultant on the weekend will come and say, well, oh, I'm not sure how this person was yesterday or day before, and let the usual team make that decision on the Monday. So by a simple defined criteria, which is open and visible to all, you can actually facilitate that discharge. And these decisions do not have to be consultant decisions always. Other members can be empowered to make those decisions, and we will hear that a little bit later. Pharmacy and discharge letters, the TTOs and discharge letters, an ongoing issue in a lot of hospitals. We always say that these should be written up, finalized during the board round. It does not always happen. Some places have got it better than other places, but delays in writing those TTOs and discharges at the weekend or batching these jobs that, okay, I'll do them on the after the ward round, or I'll set a specific time for writing a TTO, or the porters arranging a fixed time for collecting those TTOs, or delivery time is fixed. What it will do is all these things will create workload at defined times and actually delays those discharges. It prolongs the time used to process in those TTOs, for example. We, in my own hospital, we recently did an audit on the pharmacy processes, and we noted that 25% of patients on the so-called medically fit ward were having a TTO dispensed more than once. When we looked at into this in a little bit more detail, we identified that some of the patients who were being transferred from acute ward to the medically fit ward were also getting dispensed those TTOs. Once we stop this, the 25% figure will really come down quickly to about 15 or 10%. But we could only note that when we actually did an audit. We also did some process mapping, which identified some more issues, which if you did your own process mapping, you will be able to find out. For example, coming on to the transport, again, a really key issue that, but as clinicians, we may not always be directly involved in arranging transport, but we would have heard, we know that there is often a drop in provision of transport at the weekends, and this can compound the weekend effect and contribute to the extended length of stay. But booking transport in advance, for example, can help. Site teams can be made aware of any issues at the earliest opportunity. How many of us have actually looked at their own transport issues? And I know that one of the hospitals and system have just done their first transport made event. We are also learning from other systems, and hopefully we will be producing a rapid improvement guide on transport as well as pharmacy a little bit later on. Can I move on to the next slide, please? So coming on to the weekend work. Weekend is working. Really important. And we need to be clear that discharge work needs to be urgent, not routine. And to enable those beds to be available over the weekend, hospital teams really need to prioritize discharge enabling factors, whether it is a scan or a blood test or something else. And hospital management teams should also ensure that there are arrangements and agreements within the hospital and outside of the hospital to ensure that those patient slots for inpatient investigations and tests do not change to outpatient slots when they are discharged. So for example, if one of my patients is due for having a CT scan on the Monday morning and the person is ready to go home on Friday or Saturday, if as a consultant I can be assured that my patient will actually retain that slot for that CT scan on Monday, then I have the clinical confidence and reassurance that my patient will not be waiting for another 3 months for having that CT scan. And a lot of hospitals have actually arranged something like this, like a expedited discharge list. So when you label your scan request as routine or urgent, you could label it as point 3 as an expedited discharge. That gives us the clinical confidence that patients can be discharged safely without repercussions in discharging their patients. We also need to accept that there will be a small group of patients in whom the hospital admission may be an opportunity to get some tests done. So for example, an 85-year-old frail lady who never comes to the hospital has previously said, I don't want to have X, Y, or Z, but who lives alone. And if she is given an appointment to come back for a CT scan next morning, then such patients are not going to really come back. But if we explained this to the radiologist, for example, I think we can actually arrange most of the things by just that simple discussion with whichever department is responsible for that test. The next bit to cover on this one is the 7-day working. Often it is perceived as providing a level of cover over 7 days is enough, but we're not talking about just nominal cover. We're talking about maintaining the care and flow over the 7 days, and it requires a whole system approach to 7 days working. So for example, issues such as limited access to blister packs or to controlled drugs, or shorter pharmacy opening times, or reduced access to porters, or reduced access to transport or therapy. All these things can contribute to the delayed discharges on a weekend. So for example, therapies need to be able to cover all discharges, all discharge enabling interventions over the weekend, including provision of equipment. Not every place may have things lined up for these, facilitating discharges. Workforce is another major issue on a weekend discharges, and hospitals have tried various methods from using dedicated ANPs or nurses to using secretaries to work extra on a weekend to facilitate discharges and to do to the various administrative bits which relate to discharges over the weekends. And it is worth considering, as the challenge may be the same across the systems, although solutions may vary depending on your local hospital or system. I think safety netting is really, really important. We all want to do a good job. We all want to do a great job, but we all want to be safe. We want to be safe for ourselves, and we want to be safe for our patients. I remember in my very early days as a consultant when I joined, I couldn't figure out how do I follow up the results of the patients that I was discharging. I developed a local system that where any pending tests, for example, if I requested an X-ray in 6 weeks or a CT scan in 3 months or a blood test next week, all these tests can be listed on a live database maintained by the secretaries. And every Friday, the secretary will spend half an hour looking at all the results, chase the status, send them to me, and she will maintain that traffic light type system where there is a red, yellow, and green color coding live register. 15 years later, the system is still really going strong. I don't have to worry about it anymore because most of the times the secretaries will be able to sort it out. So I release my time in looking and chasing all those results. Similarly, a patient support helpline that we started some 6 years ago, which can provide a callback facility to patients up to 3 days after discharge for any queries. So safety netting is really, really important. It gives us that clinical confidence to do what we want to do. Similarly, Barnsley NHS Trust has done they complete a call on all patients discharged on patient pathway 0 within 24 hours to see and ensure that they are okay and nothing has been missed. And creating a safety net to discharge. Brighton and Hove do a very similar scheme, and we'll touch on this maybe a little bit later. So there are a lot of innovative and thoughtful ideas for improvement across the country, and we would encourage you to share them with us, and we can also highlight them in various forums for you. And please send them to us. Next slide, please. So Monday is time to monitor and time to reflect. So what happened to the patient discharges of patient X, Y, and Z? They were meant to go home. Why didn't that happen? Why did they not go home? It's really useful to think and reflect what can be resolved at the ward level, what can be resolved at the hospital level, and what can be resolved at the system level. And one may want to use very simple techniques such as the 5 whys to gain a very good understanding of the root cause that needs attention. And we can use the triple loop learning, the single loop learning, or the double loop learning, whichever way you want to do that. But it is really, really important to monitor and to reflect. So I hope I've kind of given some thoughts on how we could potentially improve the weekend discharges, but actually it's really good to hear from somebody who's done it. So I will invite my colleague, the wonderful Jyothi, to explain what she did.
Do you want to unshare your slides? And I'll share my slides. Thanks. Thank you very much, Amit. Okay, are you able to see the slides?
Yeah.
All good, Jyothi.
Okay, sorry. Yeah. So what I'll take you through in the next few minutes is simply an example of everything that just Amit has just said. This is a story of one of our wards in our hospital, and we also, like every other hospital, only have pockets of good practice. And I'll put my hand up now and say that what happens on this ward doesn't happen in some other wards as well. And you'll think in a hospital, why doesn't it happen? But there are pockets of good practice, and this is just an example of that. So this is a story of Avon ward. which is it was a GIM ward to start with, but it had predominantly diabetic consultants. So it's now a diabetic ward, and it's run by our diabetic physicians. And what they already had before they did criteria-led discharge or an attempt to do weekend discharges, they already had the consultant of the week model. And for any hospital which doesn't have that model, I would really urge to start doing that straight away if possible, because that almost lends itself to forming a team. When you have one consultant for the whole weekend, the whole team works to one ward round, and it sort of automatically, naturally, the team gets pulled together instead of multiple consultants walking in at different times. So consultant of the week model really lends itself to, making changes very easy. And I'll tell you how it is. So the story starts with, like Amit just said, before that, we always had a weekend discharge team, which was a generic discharge team consisting of a registrar and a few SHOs who toured every ward and rubber stamped the discharges which were identified for that weekend. And this was deemed necessary before discharging. So this particular ward is at one end of the hospital, and by the time the team made their way to the end of the hospital, it was either too late sometimes for the patients to go home, or something had changed, or they didn't feel confident enough to make those decisions on patients they did not know. And the team of the whole actual parent team knew the patients much better than the discharge team. So it was very frustrating for these nurses, and they said, look, why don't you tell us exactly what you want, and we will do the discharges, and instead of waiting for this discharge team, which they don't know our patients at all. And anything that actually comes bottom up like this from the team itself, I can tell you it's most likely to A, succeed, and B, be sustainable, because they are the ones who are doing it and they're not being told by others. So this is what started the whole journey. So the aim was, A, you tell us what the criteria and we will discharge, and then we don't have to wait for the senior doctor or the discharge team to come and discharge. So this is what they wanted to see, and what they wanted to see is whether they could increase the weekend discharges by doing it. So it all started by increasing the weekend discharges. That was what they wanted to do. During the week, they thought the consultant is there every day anyway, so it won't make a difference, but weekend discharges is what they wanted to concentrate on. So the process was exactly like Amit said. On Thursday, they would identify all the potentials for the weekend in their board round and go on the ward round. And then once they've identified the potential, they start informing the family and making all those arrangements. On the Friday board round, they firmed up the list of patients. Yes, they definitely can go home. And by Friday afternoon, we have what's called the CLD stickers, which will list the criteria for the patients going home. And we borrowed these stickers from South End, and we just started using them. And they were put on the case notes of the patients going home. And at the same time, there was a list of just on a Word document on the patients who were identified for going home that weekend. So on Monday at the board round, they would review that list, the Word document, and say, this is the list of patients that we thought should go, and did they all go? And if they did not go, why not? And 75% did go home, but then 25% did not. And the feedback was, the criteria weren't really very clear, or, there was a lot of ambiguity, or, basically we didn't understand that better. So basically they improved, this feedback loop was so really important because it helped the consultants to improve, change their practice, and they got better and better at becoming less ambiguous and more specific at writing those criteria. So they changed their practice, and there was a lot of challenge every time they wrote something. Oh, I don't understand that. Can you be more specific about that? So basically, we assume people understand what we have in our mind, but we don't know that it's not clear. So this sort of continuous feedback loop changed their way of thinking, and they started becoming more specific. Now, what was really useful, I mean, what came out of all this was much more, much more of a surprise for the whole team. What they've set out to do was just weekend discharges, but because it changed the culture of the team so much, they became so much better at putting that challenge. They became so much better at improving their criteria, and writing them down well, that even the weekday discharges increased dramatically. So they became really, really good at doing this. And this is the lesson really for everyone. It's the culture of the team that really made the difference, not just for weekend discharges, but the weekday discharges. And I'll show you how here. So this is some data to show. This is, as I said, it was going on from May 2017 it started. And this is the time in the middle where they started doing this active pull consultant of the week model. They started drawing all the patients who are diabetic into their ward. And by doing that, the patients get the right treatment by the right team first time. And already by just doing that, their length of stay on their ward comes down. And when they start doing criteria-led discharge, it falls down even more. And this is what they did to the weekend discharges. And this is year on year, the bar charts are showing. The last one is an incomplete year, so forget about that. So just concentrate on the two middle bars. And this is when they started doing the active pull for consultant of the week and the physician of the week model. And this is when they started doing the criteria-led discharge, and you can see the increase. And the weekend discharges increased by a number of 25 only. But what it did to the total discharges, so the weekday discharges really went up much more dramatically. It increased by 163, which means, a 20% rise over the previous year from the same ward, same team. So this is what it does. And what are the sort of team attitudes which are conducive to this criteria-led discharge? This criteria-led discharge, which you can do over the weekends, need to be, you need to be able to have a flattened hierarchy within the team. You should be able to have a team where respectful challenge is normal and it is to be encouraged. So if you're saying this is the plan, you should have your team, anyone who is in the team should be able to challenge that plan and say, why can't it be this? Why can't it be something different? Why can't they have an investigation outside the hospital? Exactly the sort of things which, Amit just said. So this respectful challenge should be the norm and it should be encouraged. And as a team, every member should know what are their jobs, and they should take responsibility for the jobs and also make sure the jobs are allocated fairly. Now, this team, I hope I did invite this our consultant to come and join the team if it was, join the call if it was possible. But this team, the whole team, no one leaves until all the jobs are completed. And that is such a good, thing to have. So if you finish your work, you help others, and the whole team, including the consultant, leave together. And that really just gives you such a fantastic, well-supportive, attitude and culture of the team. Now, this is the consultant, and I don't know if she's on the call now, but if she is, I don't mind embarrassing her. She tells me that if I take a junior doctor or nurse with me on the call, not to scribe, but because they can challenge my management plan and push my boundaries. And I think that is such that humility and that attitude is so good. So the lessons we learned is that the CLD or the weekend discharge was just a beginning of something which we set out to do to increase discharges. But what was really important is that it's a culture change. It is not about stickers. It is how you work as a team and challenge each other. And what it can do is not necessarily increase the weekend discharges, but increases the weekday and the pre-midday discharges as well. So more timely discharges. It increases the bed utilization and also decreases the length of stay. That's it, really.
Jyothi, thank you very much. Also, huge thanks to Amit and Leigh for presenting both the sort of the conception of the rig, the content, and the clinical translation. That was really helpful. There's been lots of stuff in the chat. I just wanted to engage the audience a little bit. Could I just ask everyone on the call, could I just get you to raise your electronic hands if you are doing criteria-led discharge at the weekends, just to see who's doing it, if that's okay.
Hello, Andy.
Oh, hi. Sorry, I was on mute. So we got four people from 3 organisations. I didn't want to call people out, but if anyone would like to share their experience, that's always valuable, and they could keep their hands up. So Ian, do you want to come in from Leeds, and then Ben from Surrey and Sussex? Ian, what's your experience of criteria-led discharge been at the weekend?
So ours is not just a weekend model. I think it's fair to say it's something that we try to do throughout the week. I think what we found is it's something that often happens quite organically anyway, and what we needed was to find a way of trying to formalize it. So we've got something, I suppose, akin to the sticker. We've got a system called the Patient Pathway Management (PPM), and there is now an electronic form which forms part of the EPR for the patient, which is viewable by all staff, and it's completed within about 20 seconds. Really, it's just a few clicks, but you choose your parameters for that patient, whether that be around their investigation results or their general fitness or anything, any of the other parameters that are available, and that's set then, and that's used by the weekend team. So we have, as most organisations will have, reduced medical presence over the weekend, but that then allows for the nursing teams and the other ward-based teams to be able to pick up that and assess the patient against that criteria and decide whether the patient is ready at that point then to be discharged over the weekend. I have to say it's very much in its infancy, and it is, it's not widespread in wide use at the moment, but it's certainly a good step forward for our organisation.
Oh, thanks so much. And we maybe we could link in with you and build a sort of case study around that with you. I see Erica's on the call and nodding her head, so that'd be really interesting. It'd be really good to hear your experience about how you set that up, how you design the project, what challenges you face, and maybe we could bring back and share that as an example. Thank you very much. Ben, you kindly stepped up as well. You're doing it in Surrey and Sussex.
Well, so what we're doing is not a shareable example, but I can explain what we are doing if that helps. So we have something called Patient Tracking System, which is a standalone database that our medical staff use to hand over patients at the weekend, and they hand over people with jobs to do or sick patients and people who could be discharged, but it's medical to medical, and they choose either a registrar or a junior doctor. And so I think what we're hoping to do is learn from others about actually expanding that to make sure that it's embedded across every single ward of the hospital, and also we involve the nurses much more in the decision making. So ours isn't a shareable example, it's just something that we do partially.
Lovely, thank you very much, Ben. It's really great, and thank you for being honest and open about it, and it's really important. It's interesting to me, so looking at the vast majority of people on the call today are in organisations that are not doing criteria-led discharge, and we know that the evidence for this started out either in paediatrics or elective surgery. One of the things that I'd be interested in discussing with colleagues is whether people should start with criteria-led discharge in a surgical setting and then move it and share that learning with on a medical ward. Amit, let's come to you. What do you think about that?
Absolutely.
That's very positive. Thank you, Amit.
Do that again.
So that feels like a good idea to you. Does your organisation do criteria-led discharge in the elective surgical wards?
Yes and no. So I think it's a bit of a hit and miss. I think it largely happens more on the medical wards. I think the surgical wards, some wards are kind of trying to do it in their own different ways. Yes, it does happen, but it's not as well developed, and some wards are better than others.
Okay, thank you again for your honesty, Amit. So Jyothi.
Yeah, definitely. It sort of lends itself very, very well for surgical wards. And as far as I know, in my trust, at least, I know that on surgical wards, it's a normal thing. We don't even, the nurses don't even ask us. They just know when to discharge, catheter out, this one out, and they know that the patient is ready to go. It's only when they have a doubt, then they come back to registrar to the consultants. So it's a pretty normal thing, especially on day units and stuff. They just discharge without, getting the rubber stamp from consultants, because they know they have the criteria.
Lovely, thank you, Jyothi. I'm going to move us on, if that's okay. We've got some really good questions and comments in the chat box. A couple that I'm going to acknowledge, and then one that I'm going to expand on, if that's okay. And just to give people, individuals a heads up. So Ray, you've put in a really interesting comment in. I'll come to you shortly. But just wanted to acknowledge Fiona's comment around therapy and functional discharge criteria. And we have got improvement guides on this and the clinical criteria for discharge and things. So we'll, I don't know, Leigh, whether you want to pop your email address in the chat box and pick that up directly with Fiona, if you wouldn't mind. But there will be some more stuff on that, Fiona. And Jim, just to acknowledge that they're doing a criteria-led discharge with a dedicated medical team, keen to explore nurse-led criteria. And there's going to be a presentation from Liz Lees-Deutsch, who's a consultant nurse. I think now she just moved to Coventry, hasn't she? Forgive me if I got that wrong, from Birmingham. And she'll be giving one of these webinars in due course. So just to acknowledge those there. Ray's asked a really key question. I'm going to ask Ray if he wants to come on the line and just reiterate that for everyone. Ray?
Is that Ray meaning me?
Yes,
my name is
sorry,
not
Ray.
Ray, that is Piyush is my name.
Oh, I'm so sorry, Piyush.
No
I'm reading it in sort of Teams, no not problem. Very helpful. Welcome.
I have worked with Amit and you see a lot of other people, you see Jyothi as well. The reason why discharges actually don't happen over the weekend is because they're not sure whether, because you have not seen the patient yourself. No one wants to take that risk, and no one has been reported to the GMC for not discharging anybody. But if you discharge and the patient then ends up being readmitted or to harm, then is this problem. So what we do in our NHS is that we investigate issue too much and we don't let go. We try to say that you are at risk of staying in the hospital. How many times have we asked the patient, do you want to go home? If the answer is yes, you want to go home, then why then give them the risk. That what is the risk of them staying in the hospital and going home? And the other thing that I wrote in the chat was about the firm. If you have the consultant of the week, as basically Jyothi has just mentioned, we used to have the firm system where everybody felt supported. Now we have so many locum consultants who go around, and even if you have decided, if one consultant has decided that the patient should go, locum on the weekend then decides that the patient is not able to go because he or she will not want to take that risk. So that creates a big problem, and that lack of consistency is why we have so many patients not going home over the weekend when it has been decided by the team that this patient should go home, and then you return and think why have they not, and then you discover that it has been a consultant who has decided not to discharge. So that's all I have to say basically.
Piyush, thank you, and apologies again for getting your name wrong, but
no problem at all.
I think if it helps, I think what you've verbalized would be common concern, certainly for me in my own organization and for others on the call. So thank you. That's really key points. I'm going to bring that into to the panel. Jyoti's already chomping at the bit to come in, I know. So Jyothi, what are your thoughts? So there's two aspects, just to split this down. One is on sort of workforce continuity, and one is about safety netting. And maybe if we park the safety netting and bring Leigh in on that, but Jyothi, the workforce and the continuity particularly, what are your thoughts?
Yeah, that is exactly what I think the team on an A1 ward showed. The frustration for the team which knew the patient very well, that is your nursing team, they know the patient very well. They know much more about the patient than the locum consultant who comes over the weekend. So that is why they wanted to be able to, be empowered to discharge. So could that be possible, Piyush, in your organization where the team that knows the patient and who actually does the continuity, they are able to discharge? And
we don't have any locum consultants over the weekend. We have abandoned locum consultants over the weekend now.
Okay, so that, yeah, if you empower the same team who's got the continuity and who knows the patient and they can discharge along with the safety netting, which Leigh will just describe, I think then everyone's back is covered, because you're risk sharing with all the safety netting, you're risk sharing, so that even if they have to come back and I don't like the word failed discharge, but even if they have to be re-escalated back into into our system, it's a shared risk. Yeah.
Thanks, Jyothi. And before I bring Amit in, just to say that actually, if people use the acronyms that we put in the rig and monitor on a Monday, you will see that pattern developing. That may not solve the solution, but you'll be mindful and cognizant of it, and therefore may be able to mitigate against it, as you've done just by not using locums at the weekend. So great, thank you, Amit.
I think the point I was going to mention was anyway now, but I think that is where the key area around documentation comes in, because if Piyush, if you or I have documented as a regular consultant in the medical notes, saying, okay, well, this person looks well today, if he can walk to the toilet, if the CRP has come down to less than whatever it is, and if the person has not developed anything new, then they are ready for discharge tomorrow, provided that care package is available or whatever that might be. So I think that actually really gives whether it is a locum consultant or a ward manager or whoever else is there on duty, that clinical confidence as well as that safety netting, that if I discharge this, that risk is shared. And I totally agree that a lot of clinicians are deterred by the fact that they could be potentially blamed for making a decision, but that clinical confidence to make that decision is absolutely vital, and we can all help by documentation of clear plans, especially on Fridays, but throughout the week as well.
Yeah, Amit, thank you. I think there's a really important point there. So the pro formas, and we've put some examples in the chat, not only serve as a communication tool, but as an audit tool and our clinical documentation. So that does provide a level of governance and clinical confidence around this. So that's really important. Before, Leigh, I bring you in about the safety netting, because I know you've got a really great case study that I would really urge people to look at. There's some comments coming in around functionally optimized, medically fit for discharge. And I don't think we have time to explore that today, but it's something we will pick up. There's a lot of discussion at the moment about the term terminology and the language are medically fit for discharge from a personal perspective, from a physician's perspective, does not reflect good multi-professional working. So I think we hear those points, and we'll pick them up in future webinars if that's okay. And just on that point, with our feedback forms, you'll be sent a feedback form. If there are things like that you'd like to feature in future webinars, please let us know and we'll set one up. They're relatively straightforward to do. Leigh, over to you. There's a case study that you kindly highlighted on our podcast channel with Barnsley, I think, and I don't know if that was the one that you were going to highlight. They had this great safety netting, I was going to say service, but you know what I mean, sort of culture. Yes. Within Pathway Zero. I don't quite know how to describe it, but it's a great video for people to watch. So talk us through that.
It is, and rather confusingly, I've put up a link to another case study doing virtually the same thing in a different area. So I'll post the actual podcast as well. So Barnsley has done a fantastic piece where essentially, they are quite far down the line, but they're following up everybody in a Pathway Zero that links to their transfer of care hub. And so everybody that's discharged without any support whatsoever gets that follow up. And so if things are missed, if anything's missed at all, it's picked up within 24 hours. And that's done by a mixture of professionals and sort of more admin staff as well, to try and pick up those issues and try and deal with them as quick as they can, and link to the urgent community response to try and get a response out there as quick as possible. And I think what they've seen with that is the actual confidence from the discharging teams, especially I think it's been predominantly around some of the therapy and nursing issues predominantly, but they've had the more confidence to be able to let those patients go because they know they're going to be picked up, and they know they've got that they're not just being discharged. So those what if ones as well, maybe I'm not quite sure today, maybe tomorrow, it just stops that because you've actually got that follow up the next day. And so it just enables people, all of us, to be able to take that more informed risk, because you know that if something happens, it's going to be picked up. And I think this comes back down to almost the Monday audit piece around trying to understand, well, what is the constraint to do that? Because the principle is exactly the same. And I think I might try and pull Jyothi in here a little bit around the principle of safety netting is the same for whatever professional you are. It's about having that ability, literally that safety net, to be able to take a decision and know that actually if something goes wrong, there is something that stops it, that stops that person being readmitted, that stops the worry on that particular person. It's around about and doing that. And I think there's some other areas that I think Jyothi had highlighted in previous areas around how it can take different forms from a ward base right the way through to much more of a formal Consult Connect type process.
Thanks, Leigh. Jyothi, did you want to add anything to that?
No, not really. I mean, there are a number of ways you can safety net. Leigh has outlined some of them. I can give you one more example where, we have, in terms of transport, we use Warwickshire Fire Rescue Service to take patients home. And this is it's a commissioned service, and they're really good. They take anyone who's discharged within an hour, they take them. But it's not just a transport service. They actually do exactly what Leigh has just mentioned. They go and do safety checks in the house, and knowing that somebody is actually going home after discharge gives us the confidence that yes, if there's something going wrong with the patient, they will know about it before they re-enter through ED. So the Warwickshire, there are services like that which you can use just to either phone or just call on for safety checks, and that will give us much more confidence to discharge patients.
Thanks, Jyothi. And there's lots of other things. There may be other things. So third sector, we've got the British Red Cross in London have befriending services and settling in services. There are some options out there. Just to highlight for everyone, a lot of us on the call will be familiar with these services and will be familiar with language around SDEC and virtual wards. But I know from personal experience, many of the junior doctors I work with, many of the band 5 nurses are on the wards, and the band 5, band 6 therapists are not familiar with that language and are not familiar with what services are available. So I think we can do as clinical leaders a lot more to promote that and support our staff with it. Now, look, it's 1:25. I can only imagine how busy everyone on the call is, and I suspect most people are jumping from this call to another call or already double booked. So what I'd like to do is just sum up, if that's okay. We will provide a handout of ECIST resources and a digital handout of ECIST resources. So it's just got hyperlinks to all our resources. Crystal has already put a link to our futures page. Everyone on this call today, if you're not already invited to it, will be invited to that futures platform, which has got all our resources on there, all the things that we've been talking about. You'll all get a certificate of attendance. That's not necessarily for you, but what we want to do with these webinar series is ask you to share these with your ward-based teams, and it will be important for a junior doctor. It will be important for a junior ward nurse and a junior therapist for their accreditation. It's really important that we kind of, if you like, incentivize our staff to attend these events. And so there will be a certificate of attendance. There will also be the slides in a PDF format, and we will send out a feedback form. So any comments, any things, we've had a lot of things in the chat, anything that you'd like more depth on in a webinar, please let us know. I'd like to extend my huge thanks to Jyothi, Leigh and Amit for presenting today, but I'd also really like to thank everyone on the call for your contributions and everything that you put into the chat. It's been really helpful, really insightful, and I hope it's been useful. I hope you have a good afternoon. I look forward to seeing you at our next event soon. Have a safe afternoon. Take care, everyone.
Thanks, everyone.
Thank you.